Hello, everyone. We are now live. Hello, everyone. My name is Sini Stephan. It's all good, Dr. Carey. We got it. We got it. We just lost you for 1 second. We're like, no, come back. But we are now live. Hello, everyone. My name is Sini Stephan. Namaskaram to everyone. We are Malayalees for Black Lives Matter. And for the next couple of weeks, we will be introducing a structural racism series. It will be a series of discussions discussing the institution of racism in the United States. And today we are specifically talking about medical racism. And we have a few amazing panelists here today. Ayesha, I'm going to start off with you. Ayesha is a writer, lecturer, and media commentator, Ayesha K. Faines. She is also the founder of Women Love Power, which is an educational platform which explores the subversive ways in which women have acquired and wielded power through the intersection of femininity and gender politics. Ayesha, your research has been featured at Yale University, Temple University, MTV, Essence, Hot 97, and a number of other institutions, including the Grapevine TV, for which you are a featured panelist for. Ayesha is also a competitive salsa dancer in the New York City area. Ayesha, we met during the Grapevine on set, actually. I think we were together on the Islamophobia and education equity episodes.
Yes, absolutely.
I remember seeing you and I was like, oh my goodness, she is so incredible. Oh. Medical racism panel. So for all of you watching, if you want to get content, digital content that is curated and designed by Black millennials, you need to go on YouTube and follow the Grapevine TV. They also recently just started a partnership with Patreon, and they have a few episodes on Patreon. So if you want to subscribe and support a Black business, now is the time to do that. We have plugged all of that information in, as well as Ayesha's Instagram page and Women Love Power, into the comments section, so you guys can click on them, subscribe, and start learning, start educating, and hearing from Black voices.
Thank you
for being on our panel. We also have Hattie Jackson, who is an MS-BSN registered nurse from Dallas, Texas. And Hattie, you said you received your Bachelor of Science in Nursing from the University of Texas at Arlington and Master of Science in Health Informatics from Walden University. Hattie, you also mentioned earlier this week that you have been in the field of nursing for over 10 years with experience in school nursing and psychiatric nursing. So we're really excited to hear about that, especially in the aspect of Black mental health. So thank you for being here with us. We really appreciate it.
Thanks for having me.
Finally, we have Dr. Carey from, is it Macon or Macon, Georgia?
It is Macon, Macon, Georgia.
Macon, Georgia, Macon, Georgia.
You were close.
Carey, yes, yes. All right, so now I know it's a new place, Macon, Georgia. And Dr. Carey is a DMD oral surgeon. He did his medical dentistry school at the Medical College of Georgia in Augusta, and later did a residency practice at the University of Tennessee Medical Center in Knoxville, and also did the oral maxillofacial surgery residency program with Columbia University at Harlem Hospital in New York City, which is my city, hey. Yep. And Dr. Carey, you are a proud member. I know you wanted to plug this, the historically Black fraternity Omega Psi Phi, which I see you representing today. Yes. Amazing. Yes. So again, thank you all of us. Thank you all for being here. We really appreciate it. One of the reasons why we wanted to start this panel is because up till now, we've been having a lot of Malayalees and South Asians on these panels. And we said, okay, if we're going to speak about Black issues, we need Black voices. And we also understand that as Malayalees, as South Asians, it is on us. It is our responsibility to take on the ownership and the learning of racism in this country. At the same time, we also wanted to acknowledge that we need to center Black voices. So this is the first time we're having an all Black panel. So thank you all for being here. This is huge for us. This is amazing. So thank you. As mentioned before, everybody who is watching, we make sure to like our Facebook group. It is a public page. The Facebook page is public. The Facebook group is a private group with almost 10,000 members. So please request to join that. And also follow us on Instagram at Malayalees for Black Lives Matter. We will be having a Q&A section at the end of this 1 hour discussion. The last 10 to 15 minutes will be for Q&A. If you have any questions, comments, or topics you would like to discuss, not only on medical racism, but as well as structural racism, please put that in the comments. Our team members will be feeding that information to us so that we can discuss it toward the end of this discussion. One of the things that I wanted to sort of set the stage about why we're discussing medical racism is one of our first MBLM panel series. We had the founders of Shakti Diversity, Sindhu Thomas George, who discussed that there are two main forms of racism that manifests itself in the United States, and that is systemic racism and interpersonal racism. So systemic racism is an institutionalized form of racism. We see that in education, the criminal justice system, and today we're looking at medicine. And interpersonal racism is the day-to-day racism that people of color and Black people experience, right? Whether it's through hate crimes or hate speech, the interactions that one would have, whether it's through one-on-one interactions or one-on-one through a community. So those are the two different types of racism that we'll be discussing today. Because medical racism is such a vast topic, we have honed in on 3 case studies, which will allow us to know a little bit about how racism has manifested itself in US history. We will go on to discuss how that history has played a role in today's current climate in the COVID pandemic. And we'll also understand how the institutions within the United States, predominantly white institutions, PWIs, have traditionally barred and traditionally have a legacy of exclusion of Black Americans as well as other people of color within the medical field. So we'll be covering all of those topics today. And the objective of this discussion is for Malayali Americans as well as South Asian Americans to learn and understand how systemic racism is implemented within our medical structure, particularly because as Malayali Americans, many of us, there was a huge wave of immigration in the 1970s and 80s. And you see that as Malayali Americans, we came here in part through a lot of legislation that was passed in the 60s. And that was obviously the 1964 Civil Rights Act. We have the Immigration Act, the Hart-Celler Act of 1965, which allowed skilled workers to come to the United States. And those skilled workers were a lot of Asians, and Asians also includes Indian people. As Malayalis specifically, we see especially our mothers, our aunts, our women in our community, their ticket to America was through nursing, specifically nursing. And even now, when we look at first and second generation South Asians and Malayalis in America, we see many of us as healthcare professionals. We're talking about physical therapists, physicians, nurses, pharmacists, the spectrum goes on and on. So there is a sense of responsibility that we as non-Black people of color have a responsibility to Black people within this system, because we benefit from the legislation and the work and the movement that Black people as well as Indigenous people have poured into this country. So we want to thank you all for that. And let's get into it. Let's get into this discussion, medical racism. I'm going to share my screen with all of you so you see the 3 case studies that we will be examining today. So right here, we see the 3 cases we will be examining today is the case of Dr. Sims, who is considered to be the father of modern day gynecology, Henrietta Lacks, as well as the sterilization of Black women. Pictured here is activist Fannie Lou Hamer. We were going to start with Dr. Sims. This is a picture of a painting actually of Dr. Sims, and what Dr. Marion Sims is known for, he is hailed globally as a leader, right? As a model leader within medicine, as the father of gynecology. And he is most famous. He's most famous for creating what is known as the vaginal speculum. And that is commonly used in gynecology as an examination tool, as well as pioneering the surgical repair of the fistula, which is a complication from childbirth. And because of his findings and his research, he was famously known across the world as the father of gynecology. But what a lot of people do not know is that he conducted these findings and his experiments, surgical experiments, on Black women, enslaved Black women, right? Between the period of 1845 to 1849, we see that he's been very detailed in his documentation of these surgeries. He experimented over 30 surgical experiments on a 17-year-old enslaved Black woman by the name of Anarcha. She was only a teenager, and he did this without any form of anesthesia, even though anesthesia was introduced into medicine in 1846. He deliberately chose not to use anesthesia because he believed that his experiments would be more solidified without them. So by mutilating Black bodies, Black women's bodies, by cutting and mutilating and completely, this is horrific. This is just horrific. Even just thinking about it is absolutely insane to me. He conducted these experiments not only on this one woman, but 11 more women, and possibly more, because from what we know from the documentation, it's about 11 to 15, right? But possibly more. And a lot of people think, and this is something, Ayesha, I would like for us to speak about, is a lot of people think that back in the day that this is a one-time case, that Dr. Sims' case was an anomaly. But the truth of the matter is that a lot of doctors, white doctors, particularly in the South, this was common practice to abuse Black bodies in this way. So I wanted to ask you a little bit about what you know and what you can share about Dr. Sims, but also the Black experience and the history surrounding this violence, which is absolutely horrific.
Yeah, it's so crazy because I'm familiar with Dr. Sims' story, and still listening to it makes me cringe. Because there are stories like that, even though his is the most famous, that continue well into the 20th century and probably still continue against women of color, particularly Black women. But I think that any discussion that is launched into the history of Black people, and in particular Black women and their relationship to healthcare in America, has to begin with chattel slavery, at a time when the Black female body was commodified, it was dehumanized, and hypersexualized. And all of those three classifications for the Black woman's body show up, of course, in Dr. Sims' experiment. So they were a commodity to him. They were disposable to him. It was something he was using to advance himself professionally and, of course, advance, medical research. They were dehumanized in the sense that this idea that Black women don't feel pain. And I've never really understood, apparently there are actual studies that show that when they do surveys on medical students and healthcare professionals, non-Black healthcare professionals, that a lot of people do believe till this day that Black people experience less pain. And that shows up in the way that we are treated at the hospital. And then also hypersexualized, because to put this in context, at the time when he was doing his experiments on enslaved women, it was sort of uncouth to like do medical procedures on white women, because they were, well, first of all, they got to be human, but they were considered to be too fragile and too virtuous to do this kind of experiment. So the fact that Black women were seen in all of these ways allowed him and gave him the license to do this in the first place. And so I would say we have to begin because Black women have still not escaped those tropes. We still have not escaped being commodities. There are doctors who will perform unnecessary procedures on not just women of color, but on Black people, because they're getting paid by Medicaid to do so, or because they have signed off on some sort of federal agreement. So we're going to get into sterilization, but a lot of sterilization procedures feed into that. Doctors were getting paid. The more Black women they sterilized, the more money they made. So they were commodities, dehumanized into the idea that Black women are still dying in childbirth, because when we complain and we say something is wrong, it's not taken seriously. We're not believed. And of course, hypersexualized, which again goes into not just our treatment in terms of healthcare, but again into the sterilization conversation, which we're going to have a little bit later, and this idea that Black women are so promiscuous that somebody else has to come in and take ownership of their body and determine if they should have children. So nonetheless, this conversation has to begin in that place because Black women have still not escaped those tropes that stem all the way back from chattel slavery.
Yes, no, that is 100%. And in circling back to what you said about this idea that Black people don't feel pain, right? Yeah. That research is still evident, and as you mentioned, it still impacts our society today in the field of medicine, in the fact that Black people are not taken care of in the medical system because of the same ideas.
You have a woman like Serena Williams who nearly dies in childbirth, a woman with Serena Williams' money, so nothing can protect you. You can make all the money you want. You can go to the best. I'm sure she had the best doctors at the best hospital that all that money can buy. When I saw that story, when I learned that Serena Williams literally spoke up and said something is wrong and she was not listened to, I was terrified. This happened to my mother. My mother was on staff at the hospital. My mother had issues after she had me at a hospital where she was a doctor on staff, and she had complications because she was not listened to and taken seriously.
It's wild. It's absolutely insane. And no, it goes back to exactly what you were saying. Black bodies are used by white institutions and white people as commodities, right, for economic profit. And it speaks to what author Harriet A. Washington speaks about in her book Medical Apartheid, which is that she said once we had the abolition of slavery in 1865, right, African Americans had gone from a resource to a nuisance, right? And so that's where we see that once white slave owners decided that Black women could no longer be breeded, right? Breeded for having children in the plantation for economic profit.
Exactly.
Now we're going to sterilize Black women because we want to make sure that this population does not grow because it is not profitable for us, right?
We're going to justify it, not with that, but with these women are promiscuous, these women are poor, these women are indigent, these women don't know how to be mothers, all of the negative tropes, but really what you're doing is population control.
Exactly. Which leads us into the conversation of Fannie Lou Hamer. In the 1930s, there was a large eugenics movement that took place in the United States, right? And there was a wave of immigration happening, and the US wanted to control the population because they said that once we have a large number of people, we won't be able to build the society or the white America that we have in our minds, this construction of our ideal of what white America could be, right? And so it specifically targeted disabled people, it's specifically targeted Black and brown women. And in that process, in the 1930s, there was the Planned Parenthood that came into existence, and the creator of that, I believe her name was Margaret Sanger. She created something called the Negro Project, which specifically created family planning centers in the Black South for birth control. And these were forced sterilizations that happened in the 1930s. We have more than half of US states passing pro-sterilization laws in order to implement this. And Fannie Lou Hamer, this was 1930. Fannie Lou Hamer in 1961 went into surgery for a uterine tumor that needed to be removed. And without her consent, a white doctor gives her a hysterectomy. A hysterectomy.
Yeah.
It is, yes.
That's how they got away with a lot of it. You go in for an appendectomy and come out with your tubes tied. Or they would coerce you. And if you are, there's a certain prestige we give doctors, and we should, they are, brilliant. They've studied for a long time. But if you are, not as educated, and this man in a white coat is telling you that you have to do this, or I won't perform I won't deliver your child unless you agree and sign here to have a tubal ligation afterwards, you're going to do it. But the thing is, these doctors are being paid to sterilize Black women. And all of this is happening on the backdrop of basically trying to eliminate, happening in the backdrop, because it peaked, I think, in the mid 20th century, when we're trying to make sure that women don't have access to birth control and don't have access to abortions, because what we want is for white women to not have these birth control measures so they can keep having babies, but we still want to practice eugenics on, you know, the undesirables, women of color. And unfortunately, there was a time when I was younger and I didn't understand all of this. And I felt like every woman I had met over the age of 50 had had a hysterectomy. I didn't understand why so many Black women had had a hysterectomy. And that's a prime example. You go in and maybe you had a fibroid and you end up with a hysterectomy at 35. And what they don't understand is that for some of these women who had tubal ligations in their 20s, you know, that sort of thing, this ended in divorce. This ended in like mental health issues. It can be very traumatic, and it's still happening. I was actually in Canada and Vancouver for a speaking engagement last fall, and it's a very contentious relationship between the Native population there and the Canadian government, and they are still sterilizing Native women.
Yes.
So it's still an issue globally.
Yes, that is it is beyond. It is just beyond, like it is absolutely beyond. And to know that, you know, thank you for plugging in Native American women who have been affected by this, because Black women and Native Americans share a relationship in the history of the United States, right? So Native women were also being sterilized.
Absolutely, absolutely.
Yes. So thank you for acknowledging that. Moving forward into not only the topic of sterilization, but having this idea of consent, right? Consent is such a huge topic, especially in today's culture, right? Yeah. In 1951, Henrietta Lacks, right? She went in to treat her cancer cells, and her cells were taken as culture without her consent by a white doctor. And it is now the first immortal cell, the HeLa cell, that is still used in medical research today. And how does that impact what we are seeing in medical research, even within the 21st century?
Well, you have two things. One is there's a significant distrust amongst Black people and healthcare professionals. And honestly, we don't really have that much of a reason to. You know, you look at the Tuskegee experiment. I mean, nothing bad happened, you know. To Henrietta Lacks' story is a story of consent, because they even published her children's medical records without them knowing. I mean, it's just it's an example of dehumanizing Black people, but there's a history of distrust. And that works both ways as well, because now there are studies, for example, when you're treating, like, I think it's hepatitis C, most of the studies on that were done on like white men. So there are treatments now that are great, but not as great for Black people. So you try now, we really do actually need like more Blacks to sign up for some of these studies so that they can be, you know, so they can be more so tailored to the African-American population or to population of African descent. And you have people who are reluctant, understandably so. So there's this huge distrust when it comes to Black, you know, people of color and healthcare professionals.
Yes, exactly. And it also goes back to the stereotyping you mentioned about Black women, right? And this hypersexualization, this commodifying of the body. And it sort of translates, not sort of, but it actually translates into what we're seeing today in the era of COVID. And we're seeing that the Black and Native population have disproportionate amounts of death related to COVID than any other race, right? And that happens because of the number of resources, the lack of resources that are within our communities to be able to access effective healthcare that is for our community. So Hattie, you mentioned that before as well, understanding how we, as a psychiatric nurse, you understand the mental health aspect of being a Black patient and a Black healthcare provider. But you also mentioned that the structural implications of why we have this COVID disparity. Would you be able to expand on that?
Yes, I mean, when you think about the area of Dallas, a lot of the Black population is in the southern and eastern sections of Dallas, and that area is primarily a food desert. There are a lack of medical resources, lack of clinics, and you know, a lot of people are struggling right now, and this is the area where a lot of the essential workers are living, and so they have to go to work and be exposed potentially to the virus at a higher rate than most people who can afford to or have the privilege enough to stay at home or work from home. And so when people are seen in the hospitals or healthcare settings, you know, they are they aren't provided the same access to resources in their area, such as food, that they can go and eat, go and get groceries and be able to eat and stay healthy. And so that in turn, when you get sick, you have to go to the doctor, and they can't take off work. And so it's just a vicious cycle. And then, given the case studies before, there's a lack of trust. And so it's just a perpetual cycle that, it seems like it's never ending. And, when COVID hit, it just really hit home to expose how the lack of resources are really affecting the Black and Brown community.
Yes, definitely. And it also goes back to what you were mentioning, like a lot of people don't have the privilege to quarantine at home. A lot of people don't have the mobility to travel, right? And so this sort of comes back to the historical narrative of the United States, right? We often see that Black and Brown people are labeled as people with disease, when in fact, white colonizers, white settlers brought over disease from European nations, right? We're talking about cholera, we're talking about sexually transmitted diseases, syphilis, chlamydia, all of that, right? It's transmitted from Europe, brought to the Americas, right? And now we're seeing like Black and Brown people are labeled as people with disease, but what we're not also acknowledging in the medical system is that COVID is also what is considered, even though it is a great equalizer, meaning that the virus itself doesn't discriminate, the structure discriminates, right? So we're looking at a rich man's disease. People who have the access and mobility to travel, the people who have access and mobility to quarantine, people who have services within the structure of medicine, they are being treated. But then people who don't have that same structure and that privilege are being disproportionately affected, right? And that is the tale not of only medical racism within the United States, but every system that exists within the United States. And so therefore, I wanted to ask all of you, do you believe that repairs within the medical system can actually happen within the context of white supremacy?
Repairs within the medical system can happen, but just like everything, is going to be segregated.
Exactly.
And the ones who are considered higher on a totem pole is going to be more catered to them receiving the best, and then it'll be breaking down in tiers. And what the tiers would be, well, we're using the lower tiers to study the drugs, make the drugs better, and then we'll use them for the higher tiers to make them better. So either way it goes, the system will be the same. They'll create a tier. They'll keep the low economical group at the bottom of the list. They'll use them to study the drugs. And once they figure out the path and the key to success to treat a particular disease, the higher tier get the accolades. It worked better in this group, but really it doesn't work better in that group because that group wasn't the group that was studied. The group that was studied is the one that it will perform better in. They're just not given the recognition and they're not treated properly.
Exactly. And there have been several mention of a lot of COVID vaccine testing being done in Africa, which is absolutely this
It's textbook.
Yes, exactly. Exactly what it is. It's textbook. And so that goes back to the institutionalization of racism in medicine. And Dr. Carey, I know you mentioned a lot about this when we were speaking earlier this week, but HBCUs, historically Black colleges and universities, there was an attempt to build medical schools because African Americans were traditionally barred from white institutions, right? And so white institutions have a legacy of excluding Black Americans as well as people of color within medicine. And even when HBCUs built 7 medical schools within the United States between 1868 and 1904, the Flexner Report on Medical Education in 1910 forced the closure of these medical schools. And by 1923, only Howard University and Meharry Medical College remained open to study medicine, right? And so this reminds me of Tulsa and Rosewood and all of the economic Black power that happens, but then is shut down by white supremacy and white institutions within the United States. And for this reason, I wanted to ask you, Dr. Carey and Hattie, as healthcare professionals, what has been your experience in PWIs, predominantly white institutions, as healthcare professionals, but also witnessing what you see as Black patients experiencing within the care in the system?
Yes, one of the things that we have to evaluate this from the process of the path of education.
Mm-hmm.
If I sat down with you for a day, it's a good chance my path is going to be similar to yours and our experiences are going to be similar to yours. Because once you get to a certain level of education, you become a threat. Mm-hmm. And once you become a threat, they find different ways to try to not really eliminate you, but to how to push your button to distract your mind. Mm-hmm. Now, let's break it down like to Tulsa, Black Wall Street. Everybody there, basically, the majority of people there was educated. And they brought everybody can benefit. So just a community, just like I said, it takes a tribe. So in a sense, once that was realized, you have to understand too, before they destroyed that area, they went in and they absorbed some of their knowledge. Particularly Mayo, the Mayo Clinic. I'm pretty sure everybody here has heard of Mayo Clinic, the Mayo brothers. There was a doctor there that they visited frequently to learn medical procedures, to learn advancement in medicine. But once they had absorbed all the knowledge from that area, that's when it was basically no benefit for them anymore. Even though the area still was producing, it was surviving, and it was showing the world that knew about them, Black people were just as educated as everybody else. Once the outsiders felt as if they had absorbed the knowledge, they say, okay, now it's time to destroy. Mm-hmm. It wasn't because they were jealous, it was more so to destroy the upcoming new generation. They wanted to destroy the root. Mm-hmm. So the path that I've been on has been in predominantly white institutions. The things that you see, particularly in emergency rooms, you can see Caucasian patients coming in with the same symptoms as a minority patient. It seems that most of the minority patients have a longer wait time in the emergency room. Mm. Secondly, once you go to the emergency room, if it's not anything that emergently needed to be done, they also have a secondary clinic. What you will find is that the majority of the patients who got referred to the secondary clinic, so they can continue to manage their disease, were the Caucasians. Mm-hmm. That create a rotation. The rotation is created by not directing the minorities to the secondary clinic. Mm-hmm. They're patient and they learn how to manage their conditions instead of realizing or having the mindset that the emergency room is the only place that I can go because of my medical condition. Mm-hmm. And it's a mindset that created from the emergency room. Mm-hmm. Just like any area, the emergency room is a business. Mm. Even though the majority of the patients that go there, they either on Medicaid or they don't have any money, but long as they continue to rotate those patients, they're increasing their numbers. Mm. They need numbers in order to get state funding and local funding to maintain their position. So if you send out your patients to the secondary clinic, your numbers are not going to be impressive. Mm. So who do you think they will use to continue to rotate to through the emergency room so they can maintain their numbers, so they can get the supplements and also the financial support from the state and local governments. Which group do you think they would use?
Obviously the Black population.
Exactly.
Mhm.
So everything is going to be based. How can we use this group? One, it's still for financial gain somehow, some way, and to keep them suppressed.
Mhm.
Yeah.
Thank you for that, Dr. Carey. Ayesha, did you want to respond? I saw
No,
you.
I mean, I'm blown away, but it speaks again to, and I didn't even think about the ER piece. That's what you would know that firsthand, Dr. Carey, but it speaks again to the commodification of Black bodies. So whether we are guinea pigs or we are being, run through the systems in order for doctors or for healthcare institutions to make money, corporations rather to make money, either way, our health and our well-being is not at the forefront. It's a means of making money, in a white capitalist system. So
White capitalism is deeply related. White supremacy is deeply related to capitalism, right?
Yeah.
And you can't separate the two. And so that's why I was asking, is it even possible to make that progress, right, within a system that is already racist, right? But Ayesha, you mentioned also, Dr. Carey, you were speaking about the ER, and I was thinking, Ayesha, you mentioned earlier that all of your healthcare providers are Black. And that is an intentional choice. And so I wanted to know, what does the shortage of Black providers mean for Black patients in the overall quality of health for Black people?
Well, I should say they are mostly Black unless there's something that comes up and I can't find a Black person who does it. But, that's in part because my mom is a physician. So when I had a pediatrician, it was my mom's friend who she went to medical school with. Now my mom is my primary care doctor, and everyone else is extended in that network from her. But a lot of it is because my mother has seen how Black people are treated by doctors who don't care about Black people, or who have internalized a lot of the racist ideas about Black people and their bodies and their health. So personally, I'm not terrified to the point where I will resist treatment because the person's not Black. It's not that extreme, but I have a significant preference. And it's hard because there aren't as many Black healthcare professionals. One of the issues you run into with OBGYNs, particularly Black OBGYNs, good luck, because when they're there, their practices are so huge because every Black person every Black woman is trying to have this woman deliver their baby. So I actually have a Black OBGYN, but I've actually, and she is my mom's friend, but I've never had a visit with her because every time I go, it's one of her PAs, because her practice is so big, because number one, it's hard for them to stay in business. It's a lot going on anyway. But, when they do, everybody wants to go to them because at this point, Black people have sort of realized we've seen these health disparities. They're not numbers for us. They are experiences. They are things that have happened to our aunts and to our friends and to our moms and to our grandmoms. And we don't want to relive that.
Exactly. And that speaks to the trauma you discussed, right? The trauma that Black women and Black men face, like Black bodies, right, face all the time in the system, right? And Hattie, you mentioned about your work in psychiatric nursing. Can you speak a little bit about access to Black mental health, especially in our current day situation?
Yes, it's very limited. And we're having resources. A lot of the Black patients that we have don't have insurance, or they have Medicaid, and so they have to, with those type of services, psychiatric services are very limited under that type of insurance. And so they'll come in and they may need a longer stay in the hospital, but their insurance can't cover it. So they may stay 1 or 2 days, try to start a new medication, and then they're out the door, and then it's a cyclical situation, because then they're back in the ER. I can discharge someone before I leave in the morning, that like the morning of my shift, getting ready to get off my shift, they'll be getting discharged. And then when I'm coming back that night, I'm admitting them again, you know, because they've had a crisis, or, you know, they left too soon. And one thing I was going to speak to about providing care, I've noticed with my colleagues, is that it seems as if a non-person of color who's taking care of a Black patient have these preconceived notions, you know, or that they're difficult, or they're exacerbating their symptoms to get medication. And so, you know, I would be assigned the difficult Black girl, you know, and, you know, there's like, oh, they yelled at me, they did this and that. And when I go and take care of them, they're, you know, you see a sense of relief on the patient's face, honestly, because they feel like they're understood and they're cared for, and they feel safe, and that I would advocate on their behalf. And when I noticed that, you know, it's just something that I want to speak about to people that are watching, that, you know, if you are in the medical field and you have a person of color on staff, go out and make an effort to get to know them, talk to them, understand, you know, who they are, and understand how that some of your preconceived notions or biases may implicate how you provide care.
Yeah, no, that's very true. Thank you for that, Hattie. And as you're speaking, I'm sort of thinking about how whiteness is always centered. You know, Dr. Carey, you spoke about the ER. Hattie, you're speaking about the sense of relief that Black patients have when they see a Black healthcare professional, right? And so there's always, there's that relationship and that communication that is needed that is not in the structure of white medical institutions, right? And so what we're seeing also within the study of medicine, white bodies and white metrics are the default. And I always give this example because when I was younger, I was tested for having vitamin D deficiency. And I later found out that the vitamin D deficiency is actually, the default for it is a white metric. So even though white bodies have a particular number for the vitamin D deficiency, and so Black and brown people, when they test for it, we're known to have lower rates of vitamin D, right? And so even though we don't necessarily have a deficiency, the metric is set on a white standard. So what often happens is misdiagnosis and or late diagnosis, right? When they're leaving the ER or going somewhere else. Hattie, you mentioned the insurance issue that we're having, right? The insurance, if we can't get services for more than 2 days, then we're entering a danger zone. Like Black people are entering a danger zone of either a late diagnosis or misdiagnosis or no treatment at all. So having white bodies as the center, as the default, is highly problematic, even in the study of medicine within the United States. If you look at through textbooks, it's all white bodies, right? And even in dermatology, there's actually a young brother who has gone viral. His name is Malone Mukwende from St. George University of London. And he is currently forming a book called Mind the Gap, which examines or recognizes disease on melanated bodies, right? Because there's not enough research or studies or books that show how does disease show up on Black and brown skin. It's always showing white skin, right? And so can you speak a little bit about misdiagnosis and your experience with that, or late diagnosis within the medical system?
Can you repeat what you said? You faded out the question that you asked.
My question was, can you speak about your experience about misdiagnosis or late diagnosis within the Medicare system as a healthcare professional?
Yes, I give you a prime example. And you mentioned it several times. Pigmentation, melanin pigment. It's prominent in the African-American community and dark-skinned people, where your gingiva, which is your gum tissue, most people think it's pink. There have been patients who have gotten biopsies of the gum tissue because of the melanin pigment in there. It shows up dark with little areas of pinkness. And if you're not familiar with it, someone would look at that area and think it's pathologic. And once they think it's pathologic, they have had multiple biopsies of the site. And if the pathologist is not aware of the hyperpigmentation, they can give you melanoma. Melanoma is a light-threatening cancer. And people have had unnecessary resections of their jaws because of a misdiagnosis. Now, that is not happening now because of the understanding of melanin pigment. So that is, well, it's better now because of a better understanding and because of more African American and more people of color being part of the medical field. But just imagine, I don't study the whole part of the entire body, but I'm pretty sure this has happened in OBGYN also, because the soft tissue that's in your mouth is similar to the soft tissue in a woman's vaginal cavity. They are made up of the same cells. And as a matter of fact, there's a way of treating patients who have intraoral burning, where the tissue scars down, and they can graft the tissue from the vagina to the mouth to help them open the mouth even better.
I did not know that.
Melanin inside your mouth, there's a good chance you got melanin pigment in other parts of your body. And if someone is not aware, they can do a mixed, the wrong diagnosis and come up with the wrong treatment plan.
There's also the other side of that, which is, first of all, I'm blown away because I did not know that. But
Yeah.
the other side of that is doctors basically writing patients off because they're Black or because they're poor and they feel like they're just, disposable. So you go to a doctor who doesn't care that much about you anyway, and you have an issue, something hurts. They might run some routine tests, oh, you're fine, or misdiagnose you and keep it moving. Whereas with a white patient, they would have persisted to find the accurate diagnosis. I feel like my mom should be on this panel, but what she does is basically diagnose a cancer. And there are a lot of patients of color who went to a white doctor first and they did not get better because the white doctor sort of just said, oh, it's just this. And lo and behold, you have a life-threatening cancer that you could have known about last year.
Right.
So that happens as well. And it's simply because we're not incentivized. Some of us don't, not us, some doctors don't feel as incentivized to find a cure, find a solution, or to actually adequately treat patients of color.
Exactly. And that speaks to the theory of withering, right? And withering is the chronic stress that Black people experience over a lifetime, right? That actually contributes to someone aging, actually contributes to someone having any sort of medical symptoms that they would need to have addressed, right? So that's real, and that research is now developing on how racism has an actual impact on physical health, right? So I wanted to circle back to, so as Malayali Americans, right? And this is a question that's coming through from the team, but as Malayali Americans and South Asians, many of us are within the medical structure now, right? Since we have immigrated in the 70s and 80s. What do you think, as Malayali Americans, what are best ways in which we can advocate and show allyship to Black Americans as non-Black people of color within the medical system? And have you had experiences in which non-Black people have also contributed to that racism? And Hattie and Dr. Carey, you could speak on this. Non-Black people have contributed to that racism within the medical system. It's not just white people.
Well, again, I hearken back to just writing off the Black patients as being difficult or complaining or loud when, the same non-Black person, a white person, is doing the same exact thing, but they're just, you know, jovial, or, you know, or we need to really get him medicine now. Like, it's just, or we really need to treat his pain or treat his anxiety. You know, I know from just in the psychiatric field, learning how Black people exhibit depression and anxiety is sometimes different than non-people of color. So just learning how to recognize those attributes, and speaking up and calling it out. And like I said before, getting to know someone on staff who is a Black person, and talking with them and asking them about themselves and about who they are, and how best you can recognize those biases in yourself, so that when you do see it, you can call it out, you know, and step up and be willing to advocate for them.
Thank you, Hattie. Does anyone else want to comment on that?
Well, I'll go. I just think that, you know, there's not enough, and I don't even know how effective it is, just because white supremacy is so deeply ingrained, but there's not enough conscious bias training. And so it's not just white people who practice white supremacy or who buy into these tropes and these ideas about Black people. You know, a lot of it is also immigrants who come in and they are assimilating, and racism is the American way. So they pick up all the racist ideas too, because that's part of their, you know, process of becoming a part of the American culture. I just think it takes a certain, and I think it gets its training to become aware of conscious biases, and maybe even talking to colleagues of color, particularly to Black colleagues, to kind of maybe understand and unpack your ideas, you know, or when a colleague speaks up, you know, checking yourself, you know, because nobody ever wants to be wrong. But if someone says, hey, I think you handled this patient wrong, or XYZ, really stepping back to say, well, maybe my bias played a role in the way that I handled this patient.
Mm-hmm. So being conscious of
your biases. We all have biases.
Mm-hmm.
Yeah.
Yeah, and also having that, if we can have a way to implement that training within the medical system and medical teaching, that would also
absolutely
one step up, right, than what we're experiencing right now. Because I think they're labeling everything as diversity and inclusion, but it's more than diversity and inclusion. It's being able to understand where we hold our biases and how those biases show up in the practice of treating patients.
Yes.
And also treating our colleagues as, you know, healthcare professionals, right? In addition to that, what do you all believe is necessary to disrupt the anti-Black racism in our medical system? Because Ayesha, as you mentioned before, and all of you have mentioned, you know, the white supremacy is so entrenched in this medical system. It is the foundational block of how this medical system was built within the United States. What can we do institutionally? What is required to have that change so that Black people are getting the care that they need?
I mean, I personally think it's always, I mean, this extends to systemic racism in general. I think it will always be an uphill battle. I just don't think there will ever be a point at which, okay, well, that was easy. We handled racism. What's the next step? Like, I don't think that's ever going to happen. I think the moment where we get comfortable with progress is the moment where we start to recede again. So I do think it's going to take deliberate bias training, making that a part of the medical curriculum, the part of the curriculum for registered nurses, to understand your biases, unpack your biases, having legal checks against those biases. And there's a lot of issues with healthcare in general that makes it's incredibly influenced by capitalism. And it's unfortunate because you're in the business of saving lives, but you're also in the business of making money for shareholders. Mm-hmm. And insurance companies just have a lot of power in Washington, D.C. And so I think particularly as long as as our current healthcare system is what it is, and so profit driven, that also exacerbates any of the biases within the system as well.
Yeah. I believe having training in medical schools schools will have, but I think also a focus should be given to the patients to educate them so they can have an understanding and know how to recognize when they are being mistreated. Because when they're sick, their primary goal is to go in and get treated. And whatever someone tells them, that's the treatment.
Yeah.
So not only should we educate the future doctors, we should also have some of the future doctors train on educating the patients.
Training on educating the patients. And Hattie and Dr. Carey, have you seen any sort of meaningful bias training within your professions or an involvement of that since you've been in school and, you know, experienced
No,
your life?
I haven't seen it. My school now, well, the dental school that I graduated from has a diversity office. What type training they provide, I really don't know. I really don't know any of it.
Yeah, I was going to say that as well. Our system is implementing training, but I have not. I think with the I think COVID is taking a little bit more precedent right now. And so hopefully when everything kind of dies down maybe a little bit, they'll get back and see it as a training opportunity and make it a point of focus.
And do you think that is even a reasonable request because of the funding, right? There's already a lack of funding within Black and Brown communities, right? So is there going to be a change, or is that even a request that we can implement in the era where in COVID, you see Black people are dying at alarming rates, right? So diversity and inclusion, or this unconscious bias training, is that going to be at the forefront? And as you mentioned before, it's in the era of COVID, it's not going to be, right? And maybe after we could see that. But I do think that overall, there's a lot of work that needs to be done, as all of you mentioned, and that it can only take time. So any final thoughts before we wrap up from everyone? Anything that you would like the Malayali or South Asian community to know while not only working in the medical field, but also those who are not in the medical field, how we can be better allies to the Black community in this space particularly?
Well, in the medical field, you should, in a sense, judge someone and allow that person to educate you if they demonstrate to you good bedside manners. And really, that is something you should look in people from any community. Good bedside manners. If they have good bedside manners, that means they have a spirit that should be inclusive. So majority of the time when you see someone of color, the first thing, and this happens, you become a little reserved and you question yourself to trust that person, or you question yourself to understand this person's level of education. But just give that person a moment, a second, 1 second, 5 seconds of glance, and understand and observe the bedside manner. If they're demonstrating good bedside manner, there's a good chance that person can educate you and also treat you with the respect that you're so deserving of.
Right. And Dr. Carey, can you explain what bedside manner is? I know a lot of people in our audience are also not medical professionals.
Bedside manner is one, speaking to a patient in layman's terms, in terms that they can understand. You don't have to use what is called big words. Secondly, looking them in the eye and just showing them that you care in a caring voice. Every now and then, just gently touch them on the shoulder and then express that, hey, listen, I want to, and just a gentle touch on the shoulder will do that. And that's bedside manner, speaking softly, staring them in the eye, and just a gentle touch, and speak to them directly in a language in which they understand. And the last thing with bedside manners is to listen. Listen with focused eyes.
Thank you so much, Dr. Carey. Hattie, did you have anything else to share aside from that?
You know, I've been saying this to all of my non-Black friends. It's just educate yourself, whether that's through books, articles, and educate yourself expand your circle. Reach out to other people who don't look like you. Have meaningful, thought-provoking conversations with them. Don't just go surface level, go deep, you know, really have empathy and for them and learn. And like Dr. Carey said, just listen and listen. Don't try to pass judgment, just listen and be open to hearing from others who don't look like you or have had the same experiences as you. And then be patient with yourself. You know, it's going to take time to learn, to grow, and to apply that knowledge. And, you know, I think if we continue to have more conversations like this, then maybe we can work to demolish the system.
Agreed. Ayesha, anything else? Are we good?
Yeah, I mean, basically, I mean, to expand on that, there's just allyship in general. I would agree, particularly with expanding your circle. We have a tendency to isolate ourselves. You know, your children definitely should have friends that look like them, but they should have friends that don't look like them. And if all of your children's friends look the same, that's kind of a problem. If all of your friends look the same, you know, or at least your circle looks the same, like, it's kind of a problem. So I think we have to break out of this desire to isolate so much that we lose our ability to have compassion and understanding for people who are different than us. I think there's a benefit to, you know, when you see that article that's about police brutality or medical apartheid or, you know, anything like that, you know, just glance at it, learn more, see where your own biases are. And everybody doesn't have to be a hero or on the front lines, but it's the everyday encounters, right? It's when you're talking to someone you know very well and they're saying something incredibly racist and ignorant, and you have the opportunity, because they will listen to you before they listen to me, to say, here's another way to see it. Or when you are, you know, if you are a nurse or a doctor and you're in the hospital and you see your colleague doing something or making a decision that might be biased, and you have the chance to speak up, because it's the silence that's complicit.
Yes.
Ooh, the silence is what's complicit. That is very true. So we have speaking up, we have listening, we have empathy, bedside manner, to be able to, I think also as a Malayali, I can say that, you know, there's also sometimes sometimes we have this fear of like asking directly to Black people, like, how can we help, right? Or how can I be an advocate, or speaking up, like, how do we do that, right? Like, there's this hesitation sometimes, right? And so I've definitely done that before. And I know, speaking to other Malayali Americans, this is definitely a call to action that we do need to speak up, right? Because we do have privilege and we do have access in ways that Black people, many Black Americans in this country do not have, right? And so as you mentioned, Ayesha, some people are willing to listen to us more than listening to a Black person. And that's absolutely crazy. And
But it could also be your family member.
Right.
I mean, when we're talking about issues that of bias, not just race, because you have our biases. I've talked to other family members about biases they've had against other types of people. I've had to say, look, what you just said was sexist, or what you just said was, you know, whatever. Sometimes, you know, your family members will listen to you a little bit more, at least, than they'll, you know, or your friend or your neighbor, before they'll listen to, you know, someone who looks different.
Exactly. Yeah. So we encourage all the South Asians and the Malayalees who are listening to take that advice and really implement it in practice, especially because many of us are within the medical profession and we are healthcare providers. And so it's important to acknowledge that we do benefit from the system, and how can we be advocates? How can we be able to amplify voices that are often marginalized. So I just want to thank all of you for coming. A huge shout out to all three of our panelists, Ayesha, Hattie, and Dr. Carey. It has been such a pleasure to be able to hear from all of you and to be educated by your experiences, your knowledge, because this is something that is new, in many ways new to our community, an eye-opener to our community, and this is what we need, these conversations, just like you said, Hattie. I also want to give a shout out to my partner in crime for curating the medical racism panel, Anith Roy. You have been such an incredible woman and fierce, just incredible friend to be able to partner with in curating all this, as well as DB Collective and Brian's team, Brian Jacobs' team at large, for being able to produce all the graphics and the slides that we needed for this presentation. If any of you guys have comments or questions, all of the resources, the books that we spoke about as well, Medical Apartheid and the Immortal Life of Henrietta Lacks, all of that will be queued into the comment section. And if you have any more questions, let us know, and follow all of our panelists on social media. And we will see you in our next structural racism series discussion. Thank you, and good night from MBLM.
Bye.
Bye.
Good night. Good night.